Afternoon, good morning, good evening, everyone, and welcome to today's webinar on PEP, the Forgotten HIV Prevention Intervention, and what an important discussion to have. Before we start, I'd like just to remind everyone that we have 3 languages in this webinar specifically, so please click on the icon as it is shown on the screen, choose your language, and we will go ahead. Also, please remember to use the Q&A box at the bottom of your screen to ask questions to the panelists. We will try our best to answer those questions during the webinar, but also we will take questions live. Please prepare your questions and let us engage. Let this be a lively and fully participatory webinar. Again, my name is Yvette Raphael, and I will be your facilitator for today. And as we go through today's agenda, we have a truly fully packed agenda. And like I said, I'm hoping for a lot of engagement discussion. We will first have go through the agenda, and just a reminder of everyone who's here, we will have highlights on WHO guidelines by Matteo, the annexure of the implementation of PEP guidelines by Njambi, and the PEP meeting report by Aisha, as well as the country experience on PEP PrEP integration by Dr. Tato Chidarike. Dr. Tato, you know this is a tongue twister, and apologies for that, from South Africa. And then we will go into our Q&A, as I've mentioned previously, and we will have our closing remarks. Thank you so much, everyone, for joining, and please be engaged. And I will now turn it over to Matteo to do his presentation on the highlights of the WHO PEP guidelines. Thanks. Over to you, Matteo.
Thank you, Yvette, and thank you to the organizers and to the participants for sharing this space to talk about post-exposure prophylaxis for HIV PEP. I'll be presenting the new recommendations from WHO on post-exposure prophylaxis, which were released in 2024, but also touching on several aspects related to scaling up post-exposure prophylaxis. Just to briefly introduce myself, I am Matteo Prochazka. I'm a medical doctor and epidemiologist, originally from Peru, and I am based in Switzerland, supporting the WHO in the headquarters team for testing prevention in populations with a focus on HIV prevention. Now, PEP is part of a package of evidence-based interventions, and WHO promotes HIV prevention through a combination prevention approach, which is a package of services and interventions that have been scientifically proven to prevent HIV. So this package of interventions occurs at the intersection of evidence, human rights, and community preferences to achieve a sustained impact in HIV incidence and achieve the goals that we have set for 2030. And the entry point for combination prevention, or for any prevention approach for HIV, is HIV testing. And based on positive or negative results, we can sort clients to antiretroviral treatment services or to services that include prevention, including prevention options that are biomedical. Next slide, please. So I just mentioned biomedical prevention. Why do I mean by this? Biomedical prevention in the case of HIV is the use of antiretrovirals to prevent infection in people who are HIV negative. And we talk a lot about pre-exposure prophylaxis. We talk a lot about PrEP, but we don't talk enough about PEP. So we know PrEP is the use of antiretrovirals in people who are HIV negative to prevent transmissions before a possible exposure. And there's many options. We have oral PrEP, we have injectable PrEP, specifically Cabelet. We have the silicone ring for vaginal use, the P ring. And while many PrEP products are available, cost and supply are barriers for scale-up. That being said, we are doing much better when it comes to PrEP than when it comes to PEP. PEP is an older intervention than PrEP. It's been existing for longer than PrEP has, and is the use of antiretroviral medications in people who are HIV negative to prevent infection after an exposure has happened. So a person is exposed, and then they take antiretrovirals to prevent acquisition of HIV. In order for PEP to work, the most important part is that PEP should be offered as early as possible to individuals with suspected or with known exposure to HIV, ideally within the first 24 hours of exposure and no later than 72 hours. it is critical that PEP is offered very early on so that people can actually have the benefits of antiretrovirals blocking a more established infection for HIV. The WHO recommends taking PEP for 28 days following the potential exposure. This is usually with 3 medications. Now, PEP has been mostly used in clinical settings for example, for healthcare workers following needle stick injuries, but there's a huge potential for PEP access and use after sexual exposure in the community. We often think of PEP as something that is given in emergency settings, that is given in a negative scenario, such as sexual violence, or in the case of accidents in the workplace. However, PEP has a huge potential, and we need to start thinking about PEP in a positive way within this umbrella of choice that we often discuss. PEP is also a choice for prevention that people can make in order to protect their health and protect themselves against HIV acquisition. Next slide, please. Now, what does WHO say about PEP? In 2014, we released some guidelines on HIV PEP, which included a strong recommendation for the backbone regimen for including tenofovir and an additional antiretroviral. These guidelines were also included in the 2016 consolidated HIV guidelines that also included the use of DTG as the preferred third drug for HIV PEP. So making the regimen for PEP more similar to TLD, which is what we currently use for treatment in most programs globally. There's other options as well that can be given. However, since 2016, we have not updated the PEP guidelines, mostly because there were no new PEP regimens. However, in 2023 and 2024, we convened a guideline development group to develop new recommendations for PEP, specifically focused on how PEP can be delivered, with a focus on community settings and in task shifting. These guidelines have been published in 2024, this year in July, and they're already available online, and they can be found if you follow the link that's on the slide, which we will be sharing at the end of the webinar. Next slide, please. So what were some of the key issues that occurred in the context of developing these guidelines? First, we knew that there were many implementation issues with the current guidance and with the way that PEP was being implemented globally. We know there's low knowledge of PEP by healthcare workers. We know there's low knowledge about PEP among groups at risk of HIV, so people don't know enough PEP across the board, and then it's underutilized. This results in low uptake, but also because there's low access. So oftentimes when people know about PEP, they cannot find PEP in pharmacies, in community settings, in primary healthcare centers. And then that time window, that critical time window from exposure, ideally within the 24 hours, but within 72 hours of exposure, the window is closed because oftentimes PEP is only available after the window has passed. There's usually limited delivery points, as I was mentioning, and the availability of PEP is often restricted to just the specific scenarios that I was mentioning earlier during this presentation. Some people can access PEP in private sector, but it's very costly, which is also a barrier. There's complexities for access, such as like eligibility checklists, long screening lists that make it difficult to access PEP fast. This results in starting PEP late. A lot of people actually get PEP and are not able to complete it for 28 days because there's not a lot of evidence there's no evidence for shorter regimens, so people need to take PEP for 28 days. And there's not a lot of support sometimes for adherence, so people take PEP for example, for a week and then they discontinue. And we know that this is probably not sufficient to actually protect against HIV acquisition after a possible exposure. There is no sufficient guidance on how to transition from PEP to PrEP or how to use PEP in people who stop PrEP. And now in 2024, compared to 2016, the last time we had looked at this evidence, we know a lot has changed when it comes to scale up of PrEP. So that's why we had to create new guidelines. And there's evidence, I'm not going to list all the numbers in the panel, in the blue panel to the right of the slide, but there is evidence on low completion of PEP course throughout the course of administering PEP, which results in lack of effectiveness as well. So the key message is that we needed to rethink the systems that deliver PEP to act fast and stop HIV acquisition. Next slide, please. So what is WHO saying in 2024 on the new PEP guidelines? First of all, we need to start early. PEP should be offered as early as possible to any individual with suspected or known exposure to HIV, ideally within 24 hours, but not later than 72 hours. And TLD, which as I was mentioning before, is this fixed dose combination of TDF, 3TC, and DTG, which is recommended for treatment of HIV as a first-line treatment, can also be preferable for PEP because it reduces pill burden. So you can use TLD, a single pill a day, in order to deliver a PEP regimen to someone. We say that 2 ARV drugs are effective, but 3 drugs are preferred. So even in the absence of TLD, you could start someone with PEP using PrEP, so using just TDF and 3TC or FTC, for example, although 3 drugs is preferred due to pharmacokinetics and modeling approaches. There's also specific regimens for children, which are listed in the slide here. Now, just remember that the crucial factor that influences PEP efficacy is the time between the exposure to HIV, even possible or confirmed, and starting the PEP medication. And this is the most important consideration to have when starting PEP. Next slide, please. Now, what do we say about duration and adherence? A 28-day prescription of antiretroviral drugs should be provided for HIV post-exposure prophylaxis following initial risk assessment. And this is a strong recommendation with low quality evidence, but we do say 28 days to make sure that the person is fully protected and that the person is taking the medication daily to avoid the acquisition for HIV after an exposure. We also know that adherence is an issue. So giving enhanced adherence counseling, supporting the person to make sure that they have tools and resources personally to make sure that they're taking the pill every day, whether this is at the same time every day or in a specific part of their routine that helps, whether they have a way of counting the days that they're having to take the PEP for so that they don't miss any doses, that can support adherence, especially in the context of initiating PEP. And this is a conditional recommendation with moderate quality evidence. Next slide, please. Now, we have 2 new recommendations in the PEP guidelines. One of them is related to community delivery, and this is that HIV PEP should be delivered in community settings. And this is a strong recommendation with low certainty of evidence. The key issue here is that community delivery of PEP should be a complement for delivery in other settings with strong linkages and referral pathways to different services. So this means that we're not saying that community delivery of PEP needs to be taken out of the systems where it's currently available, but rather that it should be also made available in community settings. And these community settings can include a wide range of options. It's really taking the intervention to where people are. This is included but not limited to pharmacies, to community-based organizations, to drop-in centers, to mobile clinics, or to online delivery services. We need to think about PEP and PrEP as coming together. We have been talking about PrEP and differentiated service delivery models for a few years now, and those same approaches to providing PrEP should also include the provision of PEP to bring them closer to people. Next slide, please. The second recommendation that is new in these 2024 guidelines from WHO for PEP include task sharing. Task sharing should be employed to dispense, distribute, provide, and monitor PEP. And again, this is a strong recommendation with low certainty of evidence. This is an additional approach to providing PEP, and task sharing is the distribution of tasks across a health service to ensure that we have more hands to do the tasks that we need to achieve in order to achieve our goals. This is an additional approach to providing PEP. It requires training, support, and supervision for all health workers. And this includes, of course, sensitization on stigma and discrimination and working with key populations in many settings. It also includes remuneration. Adequate and equitable remuneration is required for community and for other health providers. These providers should also be offering a comprehensive package of interventions based on a case-by-case evaluation. This may include first-line support and offer post-sexual violence care for survivors of sexual assault as the first point of contact in line with broader WHO guidelines. And the tasks can be shared with a range of health worker teams, including pharmacists, nurses, doctors, and trained lay and peer health workers. In many settings globally, the provision of PEP is only focused on infectious disease specialists, for example, and taking the intervention broader across the health system to primary healthcare doctors, but also to nurses, pharmacists, or community lay workers can make sure that we can access this intervention in time so that it's effective. Next slide, please. So a few elements on how to provide PEP. Task sharing and community delivery of PrEP and PEP are about, as I was mentioning, bringing these services closer to people. So we need to promote task sharing to make the best use of available human resources. We need to address legal and regulatory issues for different cadres of providers able to provide PEP. We know in many countries who can provide antiretrovirals and where can antiretrovirals be provided are barriers to broader scale-up in community settings, and we'll be reflecting on that throughout this webinar as well. We also need to provide training and support and supervision for all the providers. And this oftentimes includes also developing quality assurance measures, frameworks, protocols, and establishing linkage to facilities. We need to make sure that any community services that are being implemented to provide both PEP and PrEP are following quality assurance and are being linked with formal healthcare systems so that we avoid duplication, but we maintain the efficacy and the quality of the interventions. And we can also develop partnerships for community-led monitoring to ensure these services are effective and acceptable to the people who may benefit from them. Next slide, please. Now, about PEP and PrEP and how they can relate to one another. We know HIV PEP should be an entry point for HIV PrEP for many people. Usually, PEP is given to someone who has been possibly exposed to HIV and who was not using PrEP. In many cases, as we expand the access to PrEP, PEP use can be used as an entry point to promote awareness, access, and the use of PrEP. For example, some people may prefer not to take PrEP and may want to use some other methods of HIV prevention. But some people may actually be using PEP and realize for the first time that actually they could be taking, for example, a pill every day to protect their health, and they may want to transfer to or transition to PrEP. Other people may actually want to use the ring or may want to use injectable PrEP. So giving them options in the context of providing PEP is a good option to link to PrEP services and make sure that the person stays protected, because many times these exposures can be continuous in time. And we have opportunities to making sure that provision of prevention is constant. This means that people who are completing the 28-day PEP regimen and want to use PrEP can start PrEP without a gap. They do need to be tested and show that they are HIV negative after they complete PEP. And of course, we need to assess for contraindications based on each of the products. And we are advocating for immediate transition to PrEP after PEP, especially for people who have ongoing exposure to HIV. Next slide, please. Now, what about the flip side? What about people who are taking PrEP? When should they be taking PEP? Well, PrEP works, and if people are using PrEP as directed, they would usually not need PEP. But we know that in real-world settings, adherence is not perfect, and sometimes PrEP is not being used as directed, or PrEP is being stopped. So oftentimes we have questions of people saying, I have someone who took PrEP for a number of days. They say they have been exposed to HIV. Should I be starting PEP, or should they continue with PrEP? So to decide these, to make these decisions, to decide whether PEP is needed, providers, healthcare workers in general should consider if the PrEP product used is being used correctly, the type of exposure to HIV, the networks in which the person is in and has had sex in, the time that has passed since the PrEP product of choice was last used, and individual characteristics, including gender and the use of hormones that may affect PrEP efficacy. So it really is supposed to be assessed in a case-by-case basis, but we do have some guidance to support this decision-making. Next slide, please. In general, this applies to offering PEP to people who missed oral PrEP doses. So if someone is using oral PrEP, there's this table provides some guidance on whether they should be being offered PEP or not. In general, who should be offered PEP? People who are cisgender women, but also transgender women who are taking hormones, need to have taken at least 5 doses of PEP of PrEP in the last 7 days in order to be in order to continue using PrEP. So if someone has taken less than 5 doses of oral PrEP in the last week, it's likely that they would benefit actually from taking PEP as opposed to continuing PrEP. There's an exception here with sexual exposure for cisgender men, where we know that PrEP can be a bit more forgiving. So if a cisgender man has taken PrEP like a maximum number of 3 doses in the last week, they may continue using 4 or more doses in the last week, they may continue using PrEP. However, if the range is lower, if they have taken 3 doses or less in the last week, they should have to transition to PEP. I know this can be complicated, but it's easier to digest on a case-by-case basis. It really depends on the gender and the demographics of the person that has been potentially exposed to HIV, and the pattern of taking PrEP that has happened in the last week. Based on that, we can recommend whether the person transitions to PEP or not. And in the case of doubt, it's always better to go towards PEP provision to make sure that the person is fully protected than maybe leaving someone unprotected. And I hope that this table can help shape some of those decisions. Next slide, please. Yes, I think that was the last slide. I want to thank you for your attention, and I'm happy to answer any questions as part of the webinar. Thank you.
Thank you so much, Matteo, for that presentation. Really mind-blowing. But I think for me, what is important and what I've heard here is just how we are working on with WHO to make PEP provision easy for communities. And I got excited when I saw CLM and the thought of bringing it to the community for provision. So a very exciting time. Our next speaker is Njambi, and she will talk to us on the implementation of the PEP guidelines. Over to you, Njambi, and welcome.
Thank you so much, Yvette, and thank you, Matteo, for setting us up so well. Actually, having you present before this is going to make this much easier. My name is Njambi Njuguna. I work with FHI 360 as a lead for policy and programming on the Mosaic project. Mosaic is a USAID funded project that works with countries, mainly in Africa, to help introduce new HIV prevention products, particularly focused on women. So I'll start my presentation by giving a small background. Next slide. And the next one. So what we are calling the PEP template guidelines has an interesting background. So Mosaic conducted a PEP policy analysis when we are starting off, because even though we were funded to look at PrEP, we realized that PrEP is not in a vacuum. PEP is also a HIV prevention method. And so we looked at 8 African countries and looked at their PEP policy landscape in 2023 and synthesized the PEP policy brief that summarized how these policies were outlining PEP use, illustrating how to address policy and implementation barriers, and then recommending ways to increase access to and uptake of PEP as part of HIV prevention. And then through those analyses, we came up, and of course, with the new guidance from WHO, this guided the development of what we are calling a PEP template guideline to support countries as they review their PEP guidelines now that WHO has updated those most recently. Next slide. And so these template guidelines, this is just a snapshot of how they look like. And the intent of them is really to have an adaptable guideline to support development of national level guidelines that align with WHO recommendations and guidance. These were modeled on the pre-exposure template guideline that came out first in 2020 through Mosaic as well, that do the same for pre-exposure prophylaxis and have remained updated based on what WHO is coming with, and actually does have input from WHO, and have since been used in 10 countries to expedite guidance and guideline development for new PrEP methods. So this is meant to do the same, but for PEP. Next slide. And so this shows a quick snapshot of how to use the guidelines. This is a sample. We have it in the format of areas that are standardized and areas that countries may want to modify specifically for themselves. So areas requiring national updates are indicated in red font, and I have an example here where countries can lift and just copy paste this onto their guidance and fill in the places where they are specific to the country. So this example shows the country name and perhaps the regimen that they wish to specify in their guidelines. And then we have sections that are for consideration by policymakers that are shown in green boxes that are informed by regulatory bodies, available product information, country level insights that countries may wish to include within their guidance. And once a decision is made, this text can be either added or discarded as needed, depending on how the country decides it wants to go ahead with it. And so now, next slide, I'm just going to highlight that, this adaptable template is really focusing on policymakers, technical working groups, relevant stakeholders involved in national guideline development. So sometimes this can result in a new PEP guidance adaptation of the existing one, or even an addendum based on what the country needs. And so the next slide highlights what is really included in this particular one. So we have, of course, the background where WHO has come from, the evidence, the drug regimens approved, other drug-drug interactions, contraindication, and as Matteo has highlighted, how to transition from PEP to PrEP and back, what is really needed in a PrEP visit for initiation, some of the key components, PEP follow-up visits, what is really needed there, a section on who can deliver PEP and where, and then a small annexure. So this is a table of contents. If you look at the WHO one, is quite similar, but we tease out components that countries may need to look at more specifically. And I'm going to highlight those components in the next few minutes. Next slide. And those are the key components, what I'm calling key components, specifically the PrEP eligibility, time frame to provision of PrEP, linking from PEP to PrEP, and back from PEP to PrEP. I say here PrEP prescription because I have PrEP on my brain, but actually I meant PEP, post-exposure prescription, and PEP in pocket, and other considerations. And then I want to highlight just one other resource that is complementary to this called the PEP resource package that makes be useful even for implementers as they roll out PEP within the country. So the first one, PEP eligibility, next slide, is really to talk about who can be offered PEP. WHO recommends that PEP be offered to all individuals with exposure that has the potential for HIV transmission. Looking at previous country guidelines, we tended to really segregate eligibility based on people reporting aggravated sexual exposure like assault or occupational injectable exposure. There were few instances that specifically mentioned inclusion of non-occupational injection exposures or other non-aggravated sexual exposures. And this really resulted in low access to PEP. And those who did access PEP had to look to be very inventive to do so. And here we have a quote from a female sex worker in Zambia who says that sometimes, we can't say that I'm a prostitute, they'll look down on you. So what you say is, I was drinking beer and there is this man who raped me. You can't say I did it without a condom, so I get enough money. No, you can't say that. They'll refer you to the police so that the VSC will write it as a PrEP, as a rape case. Then you go to the doctor who does lab necessities, and then you're given PEP without them knowing you're a prostitute. I think it's not really necessary to go through such hoops. So what we're asking countries to do is to consider being more expansive in the people that they will include for PEP within their guidelines, include all types of potential exposure, and consider even explicitly including people with injection-related non-occupational exposure, which may actually raise awareness and reduce stigma for people who are accessing PEP. The second thing for consideration when it comes to PEP eligibility is the HIV status of viral load of potential source. Previously, we had some policies that really advocated for testing of the source prior to initiating PEP, and even for those who are non-positive, looking at the viral load, which really led to delays and in some cases, even lack of access due to the time constraints. So, and we know that even in some cases, it's possible that we may not be able to confirm the source's HIV status. So we recommend that countries be very clear that the focus is on starting PEP early. So HIV status of viral load of potential source should not be a hindrance to start PEP. And should the source be confirmed negative later on, or if the exposure was sexual and the source had an undetectable viral load, then PEP could always be stopped. But the starting is important and with no delay. Next slide. So when you look at time frame to PEP provision, the guidelines, as Matteo just outlined, is early as possible, ideally within 24 hours, but not later than 72 hours of exposure. And stressing again that starting as soon as possible after exposure is the most important consideration when taking PEP. So when countries are thinking about their guidelines, many of them, the current guidelines or the guidelines that have been there previously were very quick to say the 72-hour cutoff. So we are asking countries to really refocus on focusing on the immediate initiation and outline that it's important to start 24 hours within 24 hours as early as possible. And this will really require us looking at key critical components. For example, HIV testing. There should be no delay waiting for HIV testing for someone to start PEP. Previously, we had some guidelines that say that first you test, and then if someone is negative, then they can start PEP. Actually, we are asking countries to consider starting starting PEP, at least the first tablet as soon as possible for someone who's HIV exposed, and then looking for a way to test this person as soon as possible. If someone is going to test positive after that, they can always transition to treatment. The other consideration is HIV testing as an option as well. HIV self-testing has been considered appropriate for PEP and PrEP, and so countries can consider including those as an option to help people get on PEP as fast as possible. Next slide. So we focus a lot on the immediate initiation, but what about if someone presents more than 72 hours after potential exposure? A lot of country guidelines really did just have a cutoff and not much detail about what happens to these individuals. They may not be eligible for PEP at that visit, but that doesn't mean that they will be necessarily turning HIV positive, or rather will test positive for HIV. So there needs to be some guidance in the guidelines on what to do in such cases, including services that they can access for potential possible exposures, explicitly mentioned in the guidelines as well. And the third component for consideration when you're thinking of shortening the timeline to provision of PEP is differentiated service delivery, which Matteo had outlined before on community distribution of PEP and task sharing. So I won't go into details on this, but we highly recommend that countries consider other sources where people can access PEP, particularly for those who may come across the exposure after hours, and how they can also be useful for reaching previously stigmatized populations who may not necessarily make it to the clinics in time for those 24 hours, so that we can accelerate access within the earliest time possible. Next slide. And then when you're thinking about linking PEP to PrEP, as I said, Matteo really did cover a lot of this. So I won't go into detail. I'll highlight a few things though for consideration for countries. So we know that the current guidelines strongly recommend switching people, or rather assessing people for continuation on PrEP who have been on PEP at completion of their 28-day regimen. And a lot of the guidelines should really clearly state any testing requirements and timeline for transition from post-exposure to pre-exposure if desired by the client. And this should be put in within both the PrEP guidelines and the PEP guidelines if they are two separate documents, or into the combined document if in one. A lot of the guidelines that are currently in existence did highlight offering PEP for those who have PrEP, for those who have repeated PEP use. We saw a lot of people, or rather a lot of policy documents talking about if someone comes back for recurrent PEP, then offer pre-exposure prophylaxis. We're asking countries to consider holistic assessment of PEP users more broadly on the individual rather than how many times they come back, because in this manner, you're able to pick up people who may need PrEP early enough rather than waiting for them to keep coming back for PEP, and offer it, and not just to repeated PEP users. Next slide. And then when you're thinking about transitioning from PrEP to PEP, again, there are some people who would prefer to use PEP on the regular. And these are people who would be given some of the tablets. That's what we're calling the PEP in pocket. But again, when you're thinking about transitioning for the regular user of PrEP, then it may not be necessarily needed because they're using it as directed. But for those who would wish to transition to PrEP, for example, if they're not using the PrEP as directed or had stopped for whatever reason, these should be started again as soon as possible after potential exposure. And then explicit instructions as given by Matteo in the previous discussion should be given based on the PrEP method, the exposure type, the time, and so on that he had outlined. And really, it's really based on the individual's client's circumstances. For people who have had oral PrEP and maybe had kept them for whatever reason at home, a consideration is restarting with a 2-drug regimen is effective, but 3 is preferred. So you could ask someone to start with the 2 drugs of pre-exposure prophylaxis that they have at home as they make their way to a health facility as soon as possible to add the 3rd drug. So that's also something that countries could consider putting into their guidelines. Next slide. And then this is the PEP in pocket I was talking about. WHO does prescribe that PEP be used for 28 days. And there's a statement that says that PEP as an HIV prevention strategy, when used periodically or frequent, is safe and effective as long as the person is using it as recommended. So we are asking countries to really consider PEP in pocket. There have been some studies and evidence that showed that people who have PEP and know how to use it may be more effective and may use it appropriately when they need it, should exposure come their way. So some people actually do use or prefer to use PEP in pocket, meaning that they would have perhaps infrequent exposure and may not want to use a regular product, but if they do have HIV exposure, having that PEP in pocket may be a useful method for them for HIV prevention. So we're asking countries to consider including this proactively in the country guidelines and not just PEP retrospectively after the event. Next slide. And so we have other considerations for PEP services, including wraparound services that are really important and key for people who may be coming for PEP services, but again, should not be a barrier. These include gender-based violence and intimate partner violence services, which are really critical to consider because a lot of the circumstances around which people access PEP do include GBV or IPV. And then country guidelines should consider including supportive first-line support or supportive first-line what we call like lives or other gender and sexual-based violence supportive structures if needed during the first assessment when a client presents for this service. And then when you're thinking about other services, we also have mental health services, pregnancy testing and emergency contraception, STI, viral hepatitis testing, condom and lubricants, harm reduction services, all really important. Again, I repeat, they should not, however, be a barrier to accessing PEP services in that if they are not available, that doesn't mean someone cannot get PEP. I thought it's important to note that WHO does say that we do not require full blood count, liver or kidney function test to start PEP. And then the last thing I want to highlight when you're thinking about country guidelines and guidance, when you're thinking about the updates that WHO have come upon, is the adherence counseling. Adherence is really key for PEP, is critical. And WHO does recommend 28-day regimen. And Matteo did highlight that there are challenges when it comes to completing that, either the completion of the regimen or even coming back for follow-up appointments. So we advocate that countries could include strategies to mitigate this within their guidelines. For example, HIV self-testing, as much as possible using the new PEP drugs, which have less side effects and pill burden, as Matteo had mentioned, presumptively counseling on side effects, putting in strategies for follow-up for PEP users with the same effort that we do for PrEP, the phone call reminders and so on. And then the next slide, I want to highlight one tool that may be useful in thinking about adherence and adherence support. And this is another additional tool that Mosaic is in the process of finalizing. It's a post-exposure prophylaxis resource package. And this tool was actually identified as a need by USAID mission in Uganda based on the gap that they noted in uptake and completion of PEP and PEP to PrEP transition among adolescent girls and young women. So they reached out through USAID Washington to Mosaic to help address this challenge. And we've been engaging through a human-centered design and co-creation process with AGYW, other end users, experts, key stakeholders, to develop this resource package of new and existing tools to help improve uptake of PEP completion and transition to PrEP among AGYW. So it has two components. The next slide, please. We have components that are to do with tools for DREAMS mentors and other peer educators. I don't know, it's not moving on my side. Yes, that one. So peers that are focused towards the DREAMS mentors and other peer educators in the community to help them support PEP users, their peers who are using PEP, so they can be able to take it up, to complete and transition to PrEP if they need it. And we're using a weekly check-in framework. So there are fact sheets, there are checklists and other training tools within that packet. And then the next slide. We do have a complementary packet for providers and programmers. So this tool for providers and programmers looks at how a step-by-step tool that supports an informed, youth-friendly, competent PEP provision in the clinic, and also supports the provider to provide supportive supervision to DREAMS mentors and other peers in the field as they work with PEP users. So this is something that's still under development and should be ready in the first half of next year. So I want to come to the conclusion. Next slide, you can skip ahead 2 slides. And really, I've said a lot, but if we could only do 3 things in our guidelines, if we can take away just 3 things in our guideline, let us please advocate for inclusion of PEP being available as soon as possible within the new guidelines, ideally within 24 hours, not more than 72 hours, but also include instructions for what to do if people are using it within 72 hours. And then the second thing is it's not required. We shouldn't put hoops for people to access PEP within our guidelines. You don't really need a baseline HIV test immediately to start PEP. Neither do you need proof of HIV status, of exposure, police letter, or other documentation to take that first pill. We can do those as we are swallowing the first pill for the people who need PEP. And then at the PEP initiation visit, let's be careful and mindful to talk about scheduling for follow-up visits for HIV testing for 1 and 3 months if possible, and consider use of other modalities to really minimize the drop-offs on adherence when it comes to coming back, including HIV self-test. So with that, I think I've come to the end of my presentation. I'll finish by saying that this document, the PEP template guideline, will be online and ready for use by end of November. What I've shown you is a snapshot of what's in there. We are refining it and we'll be able to share it with everyone publicly in the next 1 month. Thank you.
Thank you so much, Njambi. What a comprehensive presentation. You said your job was easier, but did you see how the Q&A blew up with your presentation? So exciting. You actually almost got me to start thinking about advocating. What did we do wrong with PEP in its first introduction, when we can see that it really has a place in HIV prevention? So I'm about to toy. Please, just for process, can we will have a Q&A at the end of the webinar, but also I see the presenters have already started answering questions. Please feel free to drop your questions and the presenters will answer some of those questions, but leave some of your questions at the end. Our next presenter is Aisha Ismail, and she will talk to us about the report of the PEP meeting that we had earlier this year that opened this whole can of worms. Over to you, Aisha.
Thanks, Yvette, and thanks to Njambi and Matteo. I think that was a really helpful presentation, and it's also good to see that a template is in the works to help countries implement those guidelines. So I'm going to be talking to you about a report coming out of a meeting that we had in June this year. And this was once the guidelines had been released, and we brought together stakeholders from about 5 countries to discuss what would this mean at a country level, how could it be implemented, and what were some of the key themes that were coming out. So you can go to the next slide. Before I dive into the details of the meeting, I just wanted to let you know about Insight to Implementation. So I think most people on this call are familiar with the South to South Learning Network. And just wanted to share that we recently started a new stream within the South to South Learning Network called Insight to Implementation. And it's all about bridging the knowledge to action gap. So yeah, if we go to the next slide. Okay, so a little bit about the meeting that was held in June this year. So why did we have this meeting? So we had it because we wanted to bring together stakeholders that were working in the PEP space. We wanted to have some people reflect on the new guidelines, what it meant, what it was saying, were there any questions that were coming up to the surface, and really sort of exchange ideas and think through how this could be implemented in country. And so it was a 2-day meeting that included global, regional, and country stakeholders that allowed for this inter-country cross-exchange. And we had representation from South Africa, Uganda, Nigeria, Kenya, and Zimbabwe. Next slide. Cool. So there were overall 5 objectives of the meeting. Like I said, it was to introduce the new guidelines and to reflect on them. It was also to share some new studies that have been emerging from PEP, so to share some new insights and to give space to researchers to talk about some new evidence, and then to come up with thematic strategies and practical recommendations using those insights, as well as to contribute to ideas for a PEP journal supplement in JIS. The countries were selected based on some criteria, and that was that countries were selected if they previously participated in a routes to results study that had previously taken place, or if they were a host country for the meeting. Okay, so a little bit about the key takeaways from the meeting. And I think what we saw that there were 5 key takeaways, and I think it speaks nicely to the findings that Njambi and Matteo have already touched on, and that is that PEP has really been a forgotten and historically overshadowed intervention. And this is despite evidence that demonstrates its effectiveness, and that there seems to still be key barriers that limit its availability, its accessibility, and its acceptability. And so we did spend a lot of time in this meeting unpacking recommendations to strengthen the availability, accessibility, and acceptability. And now with the new WHO guidelines being released, it's an opportune time to think through how they can be adopted, adapted, and implemented to suit the different country contexts. And so we asked regional and global stakeholders to share their perspectives on PEP. And some of the key stories that we were hearing is that PEP is definitely safe and it's effective and it's discreet, and it's really an empowering option for people to use. But like we've been saying in this webinar, it's been limited to healthcare providers in occupational settings or for survivors of sexual violence. But it needs to be expanded so that it's a product option for people and that they can choose to use it based on their lives and their context and when they need to. Next slide. But in order to do that, we need to address certain key barriers. The first is that there's a lack of public awareness about PrEP's availability, its benefits, and the sensitive time nature that needs to be taken in, particularly for those exposed to sexual violence. There's also a common theme of insufficient training and sensitization of healthcare workers on PEP protocols and guidelines and delivery in a non-judgmental setting. There's still social, cultural norms and perceptions to those that engage in high-risk behaviors, and this creates a negative association with PEP. And there was a lot of discussion on the fact that there are often weak data collection and reporting systems, which make it quite difficult to track PEP use and sort of monitor areas that could be improved in. And often PEP is not integrated into other services like broader sexual and reproductive health services or jointly delivered with emergency contraception when needed. And so weak reporting mechanisms as well. Sorry, go back. You can go to the slide. Sorry, you can go to the next slide. Cool, so those were some of the key barriers. And then we also shared some new evidence insights from the field. So I'm not going to go into the details of this, but just to share that these are 3 key studies that were presented at this meeting, but there's a whole list of documents and resources that we can share with you. So one is that Routes to Results recently conducted a study in Kenya, Nigeria, and Zimbabwe, where they looked at insights from PEP users, providers, and regulatory experts, and drew out some qualitative and quantitative findings. There's also the PEP delivery project as part of the Search PEP pilot study that's taking place, as well as some interesting findings coming out from PEP on Demand and PEP in Pocket, and that's been conducted by the Africa Health Research Institute. So we can also share these additional resources with you. Next slide. I think I'll skip over the slide because this was just what we then used. We then shared the recommendations from the guidelines, and then we broke out into rooms to sort of discuss how the guidelines could then further strengthen accessibility, availability, and acceptability of PrEP. So maybe we can just go into the recommendations. Cool. So there were 5 things that we focused on in this meeting. It was the naming and branding of PEP as one, delivery channels of PEP, the transition between PEP and PrEP and what that meant practically, looking at the policy, regulation, and legislation, as well as some barriers and facilitators that exist. So maybe I'll go into detail on each of these. So on naming and branding, there was a lot of discussion on whether the name and branding of PEP should change and whether that would increase the use and uptake of PEP. But we found that countries completely agree that there is no need to rename PEP or alter the way that it's discussed at a policy level, but really that there should be a change in the way that the messaging is delivered to raise awareness. So there should be things on when PEP should be taken, that it's very safe and has no adverse effects, that you can be taking control of your health when you should take it, that it's meant for anyone who has had a possible HIV exposure, and that we should rethink the packaging to ensure that, you know, it's discreet. And then we moved on to delivery channels for PrEP, and I think there was agreement that PEP should be integrated with PrEP, with HIV self-testing and sexual and reproductive health services, and in line with the guidelines should be delivered through communities. But I think there's still some barriers that may need to be overcome, such as regulatory challenges, as PEP does remain a prescription drug. And then I think we've been talking about this a lot in this webinar, is this transition between PEP and PrEP and what that means and how it actually works practically. And in order to implement it on the ground, I think there was some discussion about the fact that there would need to be standard operating procedures or algorithms or guidance, particularly for healthcare providers, to make it quite user-friendly on how to support and aid that transition. We need to tailor, materials for healthcare workers, clients, and pharmacists, and continue to talk about PEP every time we talk about PrEP as well. It would benefit having some guidance or visuals to show sort of when to use PEP and when to use PrEP and how this transition works, and guidelines on how to discuss it with clients. That we should offer PEP to those seeking emergency contraception and strengthen the linkage to STI services as well, and find a way to implement systems to track the transition from PEP to PrEP and vice versa. We also discussed some findings at a policy and regulation level, and I think here there was agreement that there was a need to implement the guidelines at a country level, but we would need to consider the context of each country and what that meant. And definitely consider expanding the range of healthcare workers who could prescribe PEP. So speaking to the point on task sharing that was presented earlier, and ensuring that national prevention guidelines clearly define PEP's role within the broader prevention toolkit or strategies. And then lastly, we went through some of the barriers that continue to exist and potential solutions for addressing them. And one of them was limited knowledge about PEP, and there was a lot of discussion on how to sensitize providers on the guidelines to ensure there's coaching or mentorship for providers, perhaps identifying some champions in countries and developing communication strategies and elevating PEP within HIV prevention to increase the dialogue and when and how it's spoken about. and then to address some stigma issues as well. So to align the policies with WHO, promote task shifting, educate communities on PEP. I think it speaks to that point about champions and mentors, potentially engage prominent figures for using promotion and to design user-friendly packaging as well. Yeah, and then we ended off the meeting, and each person who attended the meeting made one commitment to taking this forward. And that could include like having this webinar or developing a template that could aid the guidelines, or to publishing more on PEP, or to supporting how PEP is spoken within the communities. So commitments sort of varied, and we'll be following up with people that attended the meeting and sharing the outputs with everybody more broadly. Great, I think that was the last slide. But there is a full meeting report, and we'll circulate that with the slides of the webinar after this. Thank you.
Thank you so much, so much, Aisha, for reminding us some of us the commitments that we've made. And I put in the chat box, my own commitment was to ensure that PEP becomes part of the choice, the basket of choice for HIV prevention. And I shared that that is actually in action. That picture shows that we've added that in our advocacy. A lot said in your presentation, but I think importantly is that thinking that HIV contraceptives are, provided over the counter without any prescription. Is that not a missed opportunity? And I think as we think about this, think around advocacy, think around policy, is that not a missed opportunity? Because young people, women, access these services so easily. And there's also a question by Asina that I'm not sure is answered. Can somebody please explain what PEP in pocket means? So before we get to the Q&A and I get excited for the engagement, can we have Dr. Tato go through her presentation on country experience on PEP and PrEP integration? Over to you, Dr. Tato.
Thank you very much, Chair, and good afternoon again to everyone. Tato Shidari, I'm with the WHO South Africa Country Office and responsible for HIV prevention programs as well as HIV testing programs. So I was requested to talk to the country experiences. In this case, I will focus on South Africa. Next slide, please. And I must also say that, between Matteo and Njambi, everybody has spoken everything I was going to be saying. So I'm not sure if I should just say thank you and I agree, or if I should just continue. But it just makes it easier, I guess. Okay, Chair, I see you. So I'm going to move towards the country experience, but thought I should take us back, not necessarily to 2014, like my colleague Matteo did, but maybe to 2016. But again, not saying really much to that, but just to say that at the time, the effective treatment was really still based on TDF and 3TC, but there's now a recommendation to add DTG as the third drug to make the treatment effective. So what's important in terms of PEP is actually the timing. Start early, and I think my two colleagues have already spoken to this, and within 72 hours at the most, but as early as possible, as that determines the efficacy. And the issues then, 2014, 2016, and currently even now, are currently still very similar. We still have, despite our efforts, community awareness being very low for PEP, and availability can be a bit limited, and again, underutilization of the drug itself, and late start for clients. And then one thing that needs to be considered as we move forward, and I think Aisha also mentioned that, but Njambi as well, is to think about all the other considerations that we need. And in this case, because I'll be talking about integration, there's also the issue of STIs. We know that PEP or PrEP will not protect us from STIs. So there's a need to consider that as the healthcare worker offers PEP as well as contraceptives. Because again, should there have been, especially with sexual assault, contraception would also be considered, but also again, the move between PEP and transition towards PrEP. Next slide. So again, here I'll walk very fast because Matteo also spoke to this, but I think what we need to reiterate here is that it's very important for PEP to be started early. I think all of us have been emphasizing this. I think we can't emphasize it more, but we need to make sure that it's something that is kept, especially within the communities, to ensure that communities understand that it's very important and critical to start PEP as early as possible post-exposure. Next slide, please. So focusing back into South Africa, I think it's also critical to note and mention that South Africa is one of the first countries, I think, to adapt and adopt the initial guidelines. This is now from the 2016 guidelines. And what you're seeing on the screen is South Africa 2019 guidelines that were published in 2020. And they were not just focusing on sexual exposure, on PEP for sexual exposure, but basically on PEP for all exposures. Next slide. This is the guideline that is still used at the moment. And again, the country is considering to update, review, and revise the guidelines and align again within country prescripts to the new guidance from WHO, and the country office is supporting the department with regards to that. So the guidelines are accompanied by tools, again, to inform and guide the clinicians. I have mentioned here the 3 tools, the fact sheet, the job aid, as well as the guide to offering PEP. The job aid is very important because it provides guidance to the healthcare worker in terms of the assessment of PEP, as it's an emergency intervention in terms of initiation and the clinical management of the client moving forward. Again, the job guide also provides practical guidance now to the healthcare worker on how to offer PrEP. And then the fact sheet provides information that is needed by the client. Next slide. And this, I think we should consider that it is for all exposures. So just blow up the fact sheet here to show that it actually shows or provides the definition of PEP. As we know, we have 3 interventions in terms of ARVs. PEP is ARV-based, PrEP is also ARV-based. Then we have ART, which is long-term. And it's very important that clients understand when to take one and when to take the other. So the definition of PEP, who should take PEP, is it safe? And then, of course, at the bottom, you see all the 3 ARV-based interventions. And on the right, we see getting started on PEP. Where do we start? How do we start? When do we start? How to take PEP, and also when to come back for management as we move forward to ensure that the client did not acquire HIV, and then how to protect oneself moving forward now beyond PEP, which is where we take considerations of PrEP moving forward. Next slide, please. The next slide talks to the guide to offering PEP, which is still the tool that we saw in the other slide that I spoke to. And again, here it's important that when the counseling is actually conducted, that all this information is put together, including the counseling towards adherence. When an individual reports exposure to HIV, what needs to be done? When should that be, reported? What should be taken? When should PEP be administered? The HIV test, and I think it's important to also consider what I think it was Njambi talking about, the fact that we should not wait, even if the client may not be ready at the time or the results may not be ready at the time, but we need at least for the client to take that first pill as we move within the protocol. And then again, providing the client with a prescription to collect that 28-day PEP, and also providing the date for the next visit for management. Next slide. Thank you. And at this point, I think this is where my presentation is supposed to be kind of like focused on. And again, this has already been mentioned in the previous presentations. Integration of PEP into other services. Both PEP and PrEP are actually recommended to be integrated into other primary health services, so that they are not actually offered as a silo intervention. And this also supports, long-term support for the intervention as we move forward and sustainability. Here we talk, if you see on my right, about screening and management of STIs, especially when we talk about sexual exposure. We know that even if one is on PEP, they may not necessarily manage STIs, and that should actually be taken into consideration. We know that we manage STIs syndromically, but there are tools that one could actually use to try and get, fact-finding, get information as needed. Pregnancy, possibilities of pregnancy as well. HBV and HCV, with hepatitis, and that would also include harm reduction, and then tetanus, and as well as gender-based violence. Screening for all of this will then provide the healthcare worker with a comprehensive history for the client. And then psychosocial support is also very crucial moving forward, adherence counseling, as well as ensuring that there is combination prevention interventions that are provided to the client. Then on the left, we are seeing PEP as a primary package in the middle, and we are seeing the packages that are offered, most of which I have already explained as I spoke to the interventions on the right. Counseling and support, including adherence counseling, additional services, we spoke about screening for STIs, and also discussing the possibility of transitioning between PEP and PrEP. And Matteo spoke to that, or from PEP and PEP to PrEP, moving forward after the PEP has been finished, the 28-day. Then again, I spoke about emergency contraception, pregnancy management, and the 28-day PEP medication that comes with the adherence. And then again, that's that dose that one is provided when it comes to the intervention. I think this is probably my last slide, because it was basically to ensure that we talk to all the interventions. And then in terms of the way forward, the country is reviewing and we're revising the current guidelines to align to the new 2024 WHO guidance, and all the considerations are being put forward so that we're able to come up with a guidance that is aligned, but also that is also aligned to the country's prescripts. And I think I must actually acknowledge everyone who supported me on this. I mean, my colleagues at the HQ, colleagues at the country office, and colleagues at the Department of Health. Thank you, and over to you, Chair.
Thank you so much, Dr. Tato, for your presentation. Very informative. I think a lot of questions will come from there. So we've now come to our favorite part of the webinar, where we all engage, participate, and ask our questions. And we can do that by raising our hands, and we would take the questions from there. And can I have all the presenters ready to answer questions? I can see two hands. The very first hand is Bridget Dolly, and then after that, it's James. Over to you, Bridget. Can Bridget hear me? Am I audible, colleagues?
Yeah,
Can you hear me? Yeah,
All
I
righty.
accidentally raised my hand
Yeah.
here. You can pass. Thank you.
All right, thank you. Over to you, James. You can ask your questions and everyone else after that. Feel free to raise your hand.
Thanks, Chair. I'm James from Malawi, National Health Commission. I have a question on PEP in the pocket versus event-driven PrEP, whereby both of them are recommended for a person who can plan his sexual activity. So what would be the difference in terms of eligibility criteria for the two to choose whether to take PrEP in the pocket or event-driven PEP in the pocket or event-driven PrEP? I see there's a thin line between those two. So the first two presenters can take that one. The second one is on the use of PEP and PrEP. Now that you can plan to use PEP not as an emergency or something that you take after an accident has happened. And also PrEP is something that you can plan. So why having two pills, different pills? Is there any possibility of developing one pill that can either be used as PEP or PrEP, just depending on whether it's pre or post the exposure? Because basically these drugs, the only difference is that for PEP, the only addition is DTG plus Malawi, but otherwise the same TDF, 3TC, or FTC. Thank you.
Thank you so much. So I'll give it over to the presenters. I don't have another hand up, but please, we have 136 people on this call. Please feel free to ask your questions and engage the presenters. Over to you guys.
Hi, Yvette. I'm happy to take the first question from James, and I also know there's a question on PEP in pocket on the chat, so I'm also going to tackle that one. First, so WHO is not explicitly recommended PEP in pocket. PEP in pocket is one of many different delivery models that can happen to ensure that PEP is brought closer to people. Maybe it's one of the most imaginative and creative ways of thinking about PEP, because you're actually giving PEP to someone who has a possible exposure to HIV before they have the exposure, and they only start taking it after the exposure. And this is where it can become a little bit complicated, because some countries, some programs may not want to give PEP to people who have not been exposed to HIV, right? If we have a client, as a healthcare worker, I have a client in front of me who says, I would like to have PEP to take home. Maybe I will want to give them that prescription, but maybe there are regulatory barriers that say actually PEP can only be prescribed after the exposure has happened. So we know in some settings PEP in pocket cannot work because of those regulatory barriers. But the idea of PEP in pocket, the idea of bringing the intervention to the pocket of people so they can take it when they think the risk has happened, is what we should be going towards. There's going to be different adaptations based on context. So WHO is not explicitly saying PEP in pocket, but we are saying PEP in community settings and PEP with task sharing. Now, James' question was really good because he brings together two different approaches to prevention. One is what we used to call event-based PrEP, which now we're just calling a different dosing regimen for PrEP, and PEP in pocket. Both of them are for people who maybe are not good at planning, that are good at planning. But we also know that PEP in pocket actually can complement event-based PrEP. For example, someone may have event-based PrEP and may want to take event-based PrEP, but they're not able to plan their exposure, and then they're exposed to HIV without having taken daily PrEP. So in those cases, maybe they could benefit from increased access to PEP. So for some of these strategies, we do not need to think on one or the other. Sometimes they can complement one another. And in the context of offering choice, that can be discussed with the client so that they have options in case one of the interventions that they're using is not working or they're not being able to adhere to that.
Thank you, Matteo. Anybody else would like to respond to that question? There were two parts of the question.
Yeah, Matteo, do you want to take the part about one pill for everything, or
Maybe you can go ahead and I can complement. Yeah.
sure? So thank you. So the one pill for everything, I think the good news is I think it is one pill that's being used for most everything now, with the exception of PrEP, which is minus DTG, but it's the same pill in most countries for adults and adolescents. Is being used for treatment, is also being used for PEP. And then if we remove DTG, it's the same pill that's also being used for PrEP. So I feel like it's the same ART, just the indication that's different, depending on the circumstances of the client that is in front of you and the circumstances that have brought them to the facility for support. So I'm not sure if there's another pill that can be developed. Matteo, maybe you can talk about that, but I feel like what we have right now is fine.
Thank you. I agree with those points. In many settings, TLD is used for treatment or as PEP. And we have seen it in programs where you have the shelves and it's actually the same stock. And this, based on the indication and on the HIV status of the client, they use it as PEP or as treatment, and sometimes from PEP to treatment if PEP has not been taken as prescribed. As you say, PrEP, TDF, FTC PrEP is usually TLD minus the D. So it's just with removal of the dolutegravir, it's like a 2-drug regimen. We could go at some point for a 3-drug regimen for PrEP. It will probably be too much, but it will come at the cost of maybe at the expense of simplifying programs and just having a single medication that is provided both for prevention and treatment. I think most programs can manage the supply of PrEP with 2 drugs and the supply of PEP and treatment as TLD. One of the questions in the chat earlier was related to novel PEP options, and that's something maybe that we have not discussed sufficiently in this webinar. It's so important that we think about better alternatives for PEP too, because we are seeing so much innovation on the PrEP landscape with injectables, with the ring, but we're not hearing enough about PEP. So one of the considerations for PEP is that the absorption of the medication needs to be really fast, because we know that this time window is critical. And oral products are usually better at having that really fast absorption. You know, injectables such as cabotegravir or lenacapavir, they create a deposit and it takes a bit of time for the concentration to be adequate for protection. So oral products are better for PEP. We do have in the pipeline a number of molecules that are very early on in pharmaceutical companies that include a monthly pill, for example, that can be used as PrEP, maybe could be used as PEP as well, or even weekly pills that are also being developed for treatment, for example, that could have potential for PEP. So there is a lot of excitement and innovation in the PEP landscape for new products. One of the concerns is that it's difficult to do trials because, of course, of the ethical concerns. We know PEP works and we cannot remove any protection options for people who are in a trial, but we need to think about ways to generate the evidence because we will have a more exciting and more fit for purpose PEP landscape in the future.
Thank you so much, Matteo and Njambi. I think there's also a question around resistance. Does anybody want to tackle it? Would somebody not develop resistance if taken wrongly or if these are mixed up? And the question is in the chat. Is there any risk of resistance if somebody already has HIV and then goes on a 28-day course of PrEP? I know there's an answer, but maybe if we should articulate it and have it as a discussion point, it would be great.
I'm happy to answer the question on drug resistance. As we were mentioning, if you give PEP to someone who is living with HIV, whether they have just acquired HIV or they've had HIV for a while, what you're actually doing is treating them for HIV, because PEP most of the times is going to include TLD. It's going to be a 3-drug regimen. So you're actually treating the person and even giving same-day initiation for treatment. So the risk of resistance actually is not a high risk. It's the same as the risk of resistance of giving TLD to any person who's being newly diagnosed with HIV. In some settings, we know that PEP is being implemented as a 2-drug regimen. In those cases, it could happen that if the person is already living with HIV, well, there may be some resistance happening, similar to the resistance that we see in some cases of people who are not taking oral PrEP regularly and they have a breakthrough infection. But we know that those mutations are not of huge concern, so there's nothing to worry about. However, we keep on promoting 3 drugs as a preferred regimen for PEP, because this gives us more certainty and confidence that the person is receiving anything they need, whether that's treatment initiation or post-exposure prophylaxis.
Thanks, Matteo, for the clarification. Also, I would like to put Hasina on the spot. Hasina, would you like to articulate your question? Was it answered? Hasina? It's so high up in the questions, and I really had to look for it, but I'd really like to read it. Could you please explain how PEP in pocket works practically? Does the person have 28 days supply with them, or do they have a prescription that is filled as and when it's needed? At which stage does the person has an HIV test? Is it after or after the 28-day course? Anybody can answer that one from my presenters?
Matteo, do you want me to start or?
You can start, Njambi.
Okay.
Thank you.
Yeah, sure. So I think PEP in pocket is one of, as Matteo mentioned, is one of the more innovative ways of making sure that people have drug, or rather HIV protection, their preferred protection method when they need it. And one of the ways that it could be done, and you might see this in the guidelines, Matteo can talk more about it, is for people who are in for PEP already. They're coming in for PEP services. You may consider giving them additional PEP to go home with, an additional 28-day supply in case they have another exposure that they need coverage for. There is some study, I think there's a study in Kenya and Uganda that is using community-based PEP in pocket as well, that has shown good results with people using their preferred method. So for people who prefer using PEP in pocket, it could be an option that is given to them through the distribution mechanisms in the country. It could be packaged, if allowable, with other HIV testing options that would make someone be able to start themselves at home without necessarily coming in, like a HIV self-test kit. And then the person could come in maybe for the 28-day test, or if allowable in the country, again, use a HIV self-test kit at the end of their 28-day regimen that they started on their own. I'll pause here for Matteo to add in case there's something I've missed.
Thank you, Njambi. I think that was very comprehensive. Sorry, go to you.
Thank you so much, Njambi. There is, though, a follow-up question in the Q&A. Is PrEP in pocket recommended by WHO, and how does it deal with testing? So we've answered the testing question, but is this a recommendation by WHO? Is PEP in pocket being recommended by WHO is the follow-up question, Matteo. Sorry about that.
No worries. Not explicitly. WHO is recommending task sharing and community setting delivery of PEP. PEP in pocket is a way of doing community delivery. The reason why we cannot do a recommendation saying PEP in pocket should be is recommended is because in many settings there's going to be strong regulatory barriers that will not allow for this, related to when is PEP being prescribed. Because PEP is being, in the case of PEP in pocket, PEP is being prescribed before the exposure. And what the label says, what the indication for PEP says, is that it needs to be prescribed after the exposure. So there needs to be a bit of a regulatory view there to make sure that the act of this is very technical, but the act of prescription and the act of dispensation are being taken to the community before the exposure. And that may need review of some barriers, which is why we don't have to frame the recommendation as such. But we are very supportive of models that will accelerate access to PEP in people who may benefit from it.
And Yvette, that's why when you look at the template guideline I was talking about, the PEP in pocket is in the green box for consideration by countries as an additional model. So countries could choose to take it or leave it. although we think it would be very helpful to accelerate access and also accelerate timely access, not just access to people in the community.
Yes, Njambi, I totally get that and I understand. And that's the power, the revolutionizing of HIV prevention that we've all been working on. There is another question from Godwin. Have event-driven, and this is the elephant in the room, so I'm going to ask it in any case, just for some excitement. Have the event-driven PrEP been approved for women like it has for MSM? This was also one of the big discussions in the in-person meeting. So anybody can give it a stab, and then I would like to give over to our presenters to give us a parting shot before we close this webinar with 5 minutes to go. So the elephant in the room, who wants to take it up?
I feel like that is a WHO question, so I'm happy to take it. So I think the first point I want to make is that currently WHO is changing the way we talk about oral PrEP. We're no longer talking about daily oral PrEP and event-based oral PrEP. We're now talking about dosing regimens. In the same way that, for example, we have for treatment, a dosing regimen for adults and a dosing regimen for children. In the case of oral PrEP, we have a dosing regimen depending on populations. And this is related to biological differences, really. So we have the dosing regimen for cisgender men and the dosing regimen for cisgender women. And transgender and gender diverse people, based on whether they're receiving hormones or not, also add to one or the other group. And I won't give all the details of about the transgender specific situation, because I don't want to keep the message as simple as I can. So in the case of, broadly speaking, cisgender men, oral PrEP can be started with 2 pills. They are protected 2 hours after the 2 pills have been taken, and they need to be taking the pills daily up to 2 days after the last exposure. So it's very similar to what we used to call 2-1-1 or event-based PrEP, but we actually know that many people actually don't do 2-1-1. They do 2-1-1-1-1-1-1 for a long time, and then they stop. So we know that people were not going for event-based or daily oral. They were using a mix in the middle. So to reflect that mix, we're using this dosing regimen for cisgender men, which includes starting with 2 pills, being protected after 2 hours, and then taking 1 every day after, and 2 days plus the last exposure. In the case of cisgender women, broadly speaking, we're still recommending daily oral PrEP starting with 1 pill. Protection happens after 7 days, and then they keep on taking it, including 7 days after the last exposure. So nothing has changed in WHO recommendations currently for the use of oral PrEP for cisgender women, broadly speaking. We know that there is emerging evidence looking at modeling, looking at secondary analysis of trial data for better fit-for-purpose oral PrEP regimens for women. We're very excited about this upcoming evidence, but in the guideline development group that we convened this year for looking at PEP, we did not include this because the evidence wasn't ready yet. We will continue monitoring this. We know, for example, the UK has already released some new PrEP guidelines that include event-based PrEP or equivalent for cisgender women, but we currently do not have a recommendation from WHO on that, mainly because of the lack of sufficient evidence.
Thank you so much, Matteo. And as we come to the end of our webinar, great discussions and great questions as well, we have a poll that will come up now. I would like to encourage everyone to participate in this poll by answering these questions. But as we close, I would just like to highlight some of the things that came up. Make PrEP, PEP, I'm from the old school, PEP or PEP, part of the prevention basket. Offer PEP where clients are likely to access services, and 72 hours or 28 days. We just want to give, like Njambi say, give the people the PEP when they ask for it. We will worry about those big issues later. But importantly is that we need to ensure that they are HIV negative. So please, can we take a few minutes for the poll as we close off this meeting? Thank you.